Arginine vasopressin, or AVP, plays a critical role in maintaining the balance between salt and water. AVP is also known as vasopressin or antidiuretic hormone. AVP is formed in the hypothalamus and transported to the pituitary gland for storage. Secretion of AVP is stimulated when a deficiency of body fluid is sensed, such as an increase in plasma osmolality or decrease in arterial volume. Other AVP stimuli include medications such as diuretics and antidepressants, nausea, pulmonary infections, and mechanical ventilation. AVP acts at specific receptor sites to regulate salt and water balance. The V1A receptor is located primarily in arterial smooth muscles, and V2 receptors are located on the renal collecting duct cells. In the smooth muscle cells of arteries, AVP binds to the V1A receptor. This causes smooth muscle contraction and arteriolar vasoconstriction in an attempt to maintain perfusion pressure. AVP binds to the V2 receptor in the renal tubular cell of the collecting duct. This stimulates increased intracellular cyclic AMP and activation of protein kinase A. Phosphorylation of the microtubular subunits results in aggregation to form aquaporins, which are then inserted into the luminal membrane. Water enters through the aquaporins on the luminal side of the renal tubule and exits passively on the basolateral side into the capillary space. The action of AVP at the V2 receptor helps maintain plasma osmolality in the normal range by increasing free water reabsorption. When plasma AVP is low or undetectable, the kidney excretes solute-free water. Fluid coming from the proximal diluting segment of the nephron passes through the distal segment and collecting tubules without significant modification. As a consequence, the urine is dilute or hypoosmolar to plasma, and its volume and flow rate is high. Aquaresis is the increased excretion of water by the kidney without an increase in sodium excretion. AVP receptor antagonists, such as Vaprisol, conivaptan hydrochloride injection, act primarily by V2 receptor antagonism of AVP in renal collecting ducts. The effect of blocking this receptor results in the electrolyte-sparing excretion of free water, or aquaresis. Disrupted AVP secretion frequently results in an imbalance of salt and body water. Increased AVP secretion leads to decreased free water excretion, resulting in water retention. When this causes an excess of body water relative to sodium content, the result is dilutional hyponatremia. In patients with euvolemic hyponatremia, the total body sodium is unchanged and total body water is increased. However, there are no clinical signs of edema. Syndrome of inappropriate secretion of ADH is the most common cause of euvolemic hyponatremia. SIADH is seen when plasma levels of AVP are elevated at times when physiologic AVP secretion would normally be suppressed. Causes of this syndrome include CNS disorders such as subarachnoid hemorrhage, meningitis, and head trauma. Other causes of SIADH include pulmonary disorders such as pneumonia or carcinomas. Total body sodium and total body water are increased in hypervolemic hyponatremia, with total body water exceeding total body sodium. Hypervolemic hyponatremia is detected by the presence of edema or ascites on physical exam. Hypervolemic hyponatremia is seen in patients with edema forming states such as congestive heart failure, liver failure, and nephrotic syndrome. Specifically, in the case of hypervolemic hyponatremia caused by heart failure, reduced cardiac output results in relative arterial underfilling and triggers the pituitary gland to release AVP. Arginine vasopressin plays a critical role in maintaining the balance between salt and water. Disruption of this balance may decrease serum sodium concentration. AVP receptor antagonists like Vaprisol, conivaptan hydrochloride injection, represent a unique modality for the treatment of delusional hyponatremia.